we're getting down into the actual tissues that we're going to be treating. So the masseter, it's a muscle and it has a direct articular disc through its perimysium. So it has a direct contact. It's not directly connected, but it contacts the articular disc through the perimysium. It has two portions to it. It has a superficial and a deep layer. And it originates at the zygomatic arch and attaches into the angle and the ramus of the mandible. Again, like you were saying, the innervation is the masseteric branch of the trigeminal nerve. And its action is primarily to elevate the jaw, and it assists with protraction. So it's pound for pound the strongest muscle in the body relative to its size, and it's the primary chewing muscle. So it's a great force generator. The mandibular positioning in the medial lateral or anterior posterior combined with generation of high forces during protruded jaw position, which incision or lateral to medial power stroke requires the ability to activate distinct combinations of muscle patterns to accomplish the required task. I think I've seen somewhere they reckon that the masseter itself can generate up to 300 pounds of force on its own. And anteriorly directed by forces has been the highest relative muscle activation, with the posterior deep muscle region has the most active compartment during the different motor tasks. So the deep posterior region is the most active during parafunctional activities. So there, it's actually there, yeah. So generating a whopping range of 300 to 600 newtons in healthy adults at that posterior region. So it's a pretty strong muscle. So there's 4 common pain referral patterns that we commonly see in the masseter. It's commonly referred pain into the cheek, the jaw, and the TMJ of the affected side. Some patients can report toothaches and even tinnitus. The tinnitus, it's not that common, but just bear in mind that it can happen. The needle angle is perpendicular, oblique, and or transverse. So it's possible and advisable to pick up the tissue where and when possible to needle. So what we mean by that is, if we're going right down, we just want to be cautious, it's there actually, that we're not needling too deeply into the jaw. But we want to get through the tissue, and this is where our palpation comes in, and it's so important. The more we can locate the tissues that we want to treat, the better and more efficient we are with our needling, as opposed to just going in and just ramming around like a car wreck. So needle depth, again, it's always going to differ from patient to patient, but on average it's going to be somewhere between 1 to 1.5 centimeters, and your angle will also depict that kind of range as well. So we heard Jamie talk about the Travell and Simon books, both Jamies. I put the X's here, but always palpate, bear in mind. So the third version of the book actually done away with the X's, because hypothetically trigger points can form anywhere in the muscle tissue. They are commonly seen along the musculotendinous junctions, the MTJs. So we'll palpate the tissue and we'll ask the patient to clench the jaw. So like we were doing earlier, we're going to get tissue activation just to confirm we're on the tissue. We'll palpate. Like we were saying, don't rely on the X's. So this isn't, I've seen the picture, I've seen the X's, we're going to hit the X's. Always palpate the patient, because otherwise we're still kind of like the guy with the bow and arrow. We're just aiming and hoping. Whereas when we palpate, we're much more direct. So more commonly, pain is referred to the lower jaw, the molar teeth region, and directly into the TMJ. And sometimes it may arc across the temple and above the eye. This is just the pattern that we see. So where it's darker is normally where it's more commonly seen to be a lot stronger, and then it can diffusely spray out into the lighter red regions there. So this is the first. The second, down the lower border, you get pain in the jaw. The third, right down at the angle of the mandible. But like I was saying, we're still going to palpate through the whole tissue and not just CDX and shoot. This is the one that pain can normally refer right up in an arc over the eye, down through the whole jaw, just anterior to the ear, and down into the lower part of the jaw. And then for the deeper layer. So pain can spread diffusely into the mid-cheek, the area of the TMJ, lateral pterygoid, and the trigger points that are found close to the posterior zygomatic attachment may refer deep into the ear. So if we do hear somebody talking about tinnitus associated with their jaw movements, or it gets worse if we're eating a lot, that's where we're looking at the deeper layer of the masseter, because that's the one that has been reported to produce a tinnitus sensation. Like we were doing earlier when we were palpating, so if we can compress on that tissue and reproduce that tinnitus symptom, we do know that it's coming from that deep layer of the masseter. So it's commonly described as like a low roaring sound. So Mose has a nice little tight band here. So that's my target. And again, I'm pinching the tissue up into my hand to give me more surface area, more control over the needle and of the tissue.
Is this the superficial masseter?
Yes. There we go, we got it. You all right, Moses? Mm-hmm. So we got a twitch response from that. So I'm going to withdraw. Would I do motor points? Yes, I would. Absolutely. So I would add them. If there's trigger points, I will definitely hit trigger points and then do motor points. So in terms of motor points, I'm looking to re-establish the firing sequence of those tissues, neuromodulate, as Anthony says. In terms of trigger points, I want to restore the elasticity back into the tissue, do away with that noxious stimulus that's coming from that trigger point. There is times you can do motor points and get away with not hitting the trigger point, but traps, jaw, I find you kind of need to hit the trigger points as well.